Hi, everyone, and good afternoon to those of you on the East Coast, and good morning still to those of you in other time zones. My name is Eileen Searle. As everyone gets logged in, I'm going to start with a few housekeeping items for us today. First of all, as you're being notified as you join, this webinar is being recorded, and the recording will be posted following this to the Region 1 RDHRS website. To limit background noise, due to the large number of attendees as you're joining, your microphone has been muted for the duration of the webinar. However, we really encourage your questions and comments. If you have a question or comment at any point during the webinar, you can type your questions into the Q&A box, and we will do our best to answer your questions during our audience Q&A session at the end. At the end of the webinar, we will also be sharing a link to a short survey to gather your feedback. The information in this survey helps us develop future sessions and identify topics for other webinars. We really appreciate you taking the time to complete this 60-second survey. So it looks like we have a large number of people joining us today. So I really want to say thank you for joining us and welcome. I'm Eileen Searle. I'm the Executive Director of the Region 1 Regional Disaster Health Response System Program, which is located at Massachusetts General Hospital in the Center for Disaster Medicine. The RDHRS is an initiative supported by Health and Human Services Administration for Strategic Preparedness and Response to address healthcare preparedness challenges, expand access to specialty care, and support optimal patient care during disasters or urgent public health circumstances. As you all know, the New England region, as well as much of the country, is experiencing an unprecedented number of cases of acute respiratory illness in children and infants. The Region 1 RDHRS is providing access to resources and tools to assist hospitals, clinicians, emergency managers, and other health professionals in responding to this pediatric surge. One of the key resources we've developed is the launch of this educational series on providing care for pediatric patients with acute respiratory illness. These sessions are interdisciplinary and geared to provide clinical teams from nursing, providers, and respiratory therapy disciplines with information and resources needed to support the care of pediatric patients. Today's session on providing non-invasive ventilation for pediatric patients is the third of 6 planned sessions. We're really excited today to have a great panel of speakers here with us to present on this topic. We're joined by Dr. Ryan Carroll, who is the director of the Global Pediatric Critical Care Medicine Program at Massachusetts General Hospital. He is a pediatric critical care physician at the Mass General Hospital for Children and an assistant professor at the Harvard Medical School. Dr. Carroll hails from the anesthesiology and critical care lab started by the late Professor Warren Zappel, where he has cultivated translational research interests, including exploring the pathophysiology of cerebral malaria, building capacity in low resource settings, and more recently, generating several efforts investigating the antimicrobial effects of high-dose nitric oxide, developing and testing respiratory monitoring systems, and building innovations tailored to pediatric care. We're also joined by Carolyn Levita, who is the Director of Respiratory Care Services at Massachusetts General Hospital, Massachusetts Eye and Ear, and the Shriners Hospital for Children in Boston. Carolyn has been a registered respiratory therapist at MGH for nearly 20 years, with significant experience in adult, pediatric, and neonatal critical care, as well as extracorporeal membrane oxygenation. Carolyn has led many quality improvement and care delivery projects, including respiratory treatment for low birth weight infants, safety during tracheostomy tube change, COVID-19 pandemic ventilator allocation, and novel uses for inhaled nitric oxide, among others. Her research interests include innovative solutions to staffing challenges, staff development, the use of esophageal manometry and electrical impedance tomography in setting PEEP and prone positioning. And our last speaker today is Krista Gallagher, who is the nursing practice specialist in the Pediatric Intensive Care Unit at the Mass General Hospital for Children. Krista has been a nurse in the PICU at MGH for the past 15 years. During her time in this role, she has completed her master's degree and discovered her love for nursing education and teaching. She assumed the role of the nursing practice specialist in the PICU in January of 2022, where she is able to focus on positive patient outcomes while providing up-to-date staff education and guidance. Her special interests include burns and wound care. So we really want to thank all three of you for joining us today, sharing your knowledge and some of the operational work that you've done in providing non-invasive ventilation to pediatric patients. And with that, I will turn it over to Dr. Ryan Carroll.
Thank you, Elaine. That's great. Thanks for the introduction. We're super excited and privileged to share this presentation with you. This is a presentation that's been in the works for some time as we've encountered this surge, respiratory surge in pediatrics throughout our region. I'm just going to walk through there's some, hold on. This advance, hold on. I'm going to try it again. Of course, this is something that was working before. We do this. Apologize. Yeah, that's actually up and running beautifully. And I'm going to that should do it. All right. Sorry about that. These are our introduction slides as mentioned before. This webinar is presented by the Region 1 Center. It's funded by an ASPR funding. These are our disclosures. You can read through those from the recording potentially. Just some speaker disclosures from me. I'm a co-founder of one of a small medical device company that builds devices to objectively measure the work of breathing in children. We won't discuss these. I also have several patents on various devices, mostly for respiratory support and measurement, and we won't talk about those at all. This talk is definitely in our research and operational wheelhouse, and is an area of expertise for all of us, and we're very happy to share it with you today. The burden of need, we'll talk about a little bit of physiology and trends, the application operational approach to providing non-invasive ventilatory support for children in nursing care, which is absolutely critical, and the concepts and safety behind feeding these children. So we wanted to highlight a little bit of a background, not spend too much time on this, but this was already a massive burden of care for children globally, bronchiolitis or pneumonia. Or if you want to make that even a broader category of respiratory distress and failure. And so it's already the number one reason for admission in the United States for children under 2 years of age. It's already a great burden both globally and domestically, and up to about 20% of patients have been admitted to the ICU who have bronchiolitis. And it's the number one reason, respiratory failure, it's the number one reason for mortality in the under 5 cohort globally. We have our own internal data system, and we looked at the data and compared just briefly, for instance, rhinovirus admissions from September 2021 versus 2022 and saw a tripling. And we are all experiencing and here meeting today to address this very precipitous crescendo and very early spike in RSV compared to the most recent years. And influenza is on the horizon coming from the south and has a very similar early precipitous incline. But I think we're gathered here because we're really interested in talking about non-invasive support for children. And I think why are children really at risk of respiratory failure? They are uniquely at risk for respiratory failure. One, they have narrow airways. The velocity of flow in their airways is very, very high compared to adults. They have very high resistance. They have weaker diaphragms, pound for pound. They have weaker diaphragms compared to adults. They have compressible chests. They're very compliant. They are, I like to think of children as organic or origami, and they were just neonates, for instance, were just recently deployed, and their bodies are working hard to maintain their FRC by creating a more rigid rib and chest structure. But because they don't really have that yet, they are highly compliant and prone to collapse. In addition, children are consuming nearly twice as much oxygen per kilogram per minute than an adult. And that's at baseline. So if you add fever and work of breathing, they're consuming even greater oxygen. So here we're talking about children with sticky, sick lungs. They have high resistant airways. They have decreased muscular tone. They are prone to atelectasis, loss of lung volume, have increased work of breathing, consuming high oxygen, and actually becoming hypoxic, and they ultimately fail. And the easiest way to overcome this is CPAP and continuous positive airway pressure. And we'll go into the specifics, but it's good to sort of understand the context of the history of this a little bit. In the 1970s, this young gentleman, George Gregory, and his mentor, William Hamilton at UCSF, developed CPAP as a response to a better understanding in the late 60s that PEEP, or grunting, that children were creating was basically creating auto PEEP, and they were basically maintaining their FRC and maintaining better oxygenation by creating their own PEEP. They wanted to provide an extracorporeal way of delivering this positive airway pressure. And the way that they did this was through a very crude device at the time, a hood that went over the child's head with a diaphragm around the neck, which is sort of the inverse of the iron lung at the time. And this was affectionately known as the Gregory box. It's not too crazy though, because we've seen examples of this more recently during the pandemic. But this use of this CPAP in neonates with respiratory distress syndrome decreased mortality by 50%. And because at the time, neonates with RDS, a third of them were dying, and they reduced it to 15%. And actually, by the end of the study, reduced it down to 5%. And that trend has continued. And what we've noticed is that there's an increase in non-invasive support altogether in the last couple of years. There's a general recommendation from the AAP for neonates to use bubble CPAP or nasal CPAP. There's been also an increase in the last few years, in the last decade and a half, of use of CPAP and high flow in the clinical setting for bronchiolitis. Around 2016 or so, we noticed a trend in our own unit that we felt we were using more and more non-invasive support. And sure enough, from 2016, which is at the bottom part of this graph, up to 2020, we were noticing an ever increasing use of BiPAP. There's several reasons for that, and we'll get into a little bit later, and sort of a decrease in invasive ventilatory support. This notion was supported by a recent publication by Pelletier, et cetera, et al. In 2021, that not only demonstrated an increase in ICU admissions for bronchiolitis, but a 7-fold increase in use of non-invasive support. So this concept that we're talking about today, this use of non-invasive support, was already in the works over the last decade and a half. And this is just another way to look at that data. So what we're talking about here are respiratory support approaches. Low flow nasal cannula, we won't talk about. That's just regular oxygen. There's no pressure or CO2 washout, dead space washout. High flow, you talked about at length last week, with high flow delivering enough oxygen and flow to wash out dead space. And our lab has demonstrated it actually confers some pressure. But really, we're here to talk about CPAP and BiPAP, continuous positive airway pressure, and biphasic positive airway pressure. So to talk about that, Caroline Levita will take us through those various respiratory support modes.
Thanks, Dr. Carroll, and thanks everyone for being here today. If any of you have treated infants with bronchiolitis or pneumonia who happen to be intubated, it is incredibly difficult to manage those patients in a wake state where they can participate in airway clearance. So as an alternative to invasively ventilating everyone, now that we have appropriate nasal interfaces, we are able to non-invasively ventilate them using CPAP and BiPAP. It does provide similar support to mechanical ventilator, although not to the exact degree that we'll go into, but there are other benefits to it and all of these implications of mechanical ventilation that we can avoid. Things like using deep sedatives and or neuromuscular blockade to keep endotracheal tubes secure in these patients. With that level of sedation and perhaps paralysis, they certainly have decreased mobility. So that has long-term implications on their development, but also on immediate implications on their airway clearance and ability to mobilize secretions. They do have potential for airway injury the longer that they're intubated with either a cuffed or uncuffed endotracheal tube. And again, the longer that they're intubated, they can develop oral aversion to feeding and such things. So we'll start by talking about CPAP. It does stand for continuous positive airway pressure. The ventilator that you set, it delivers one constant pressure during the entire respiratory cycle. This helps to overcome premature airway closure and keep alveoli open and distended. The analogy that is often used when referring to lungs is something like a balloon, and you can understand that the first time that you're going to inflate a balloon, it takes a great deal of pressure to actually distend that balloon. The same applies for alveoli. At the start of every breath, to distend the alveoli and to start opening them, it takes a great deal of pressure. So if we maintain a pressure within that alveolus, the subsequent breaths are much, much easier to initiate. The respiratory therapist will set the CPAP level and the amount of oxygen. Some devices have a dial that you can actually set the fraction of inspired oxygen. Depending upon the type that you have, you may have one where oxygen is bled into the machine or added to the machine, in which case the oxygen is set in liters per minute. The typical range that you can expect for pediatric viral illness is somewhere between 7 and 10 centimeters of water. We'll talk about escalation and de-escalation in 1 minute, but I would suggest starting patients at 7, which has been proven in the literature to decrease work of breathing in these patients. You can then escalate if you don't have an appropriate response. BiPAP, or bilevel positive airway pressure, means that the pressure within the system, so within the ventilator system, the tubing, the interface, and the patient, varies with the respiratory cycle. There is a CPAP that is set, again, to maintain that alveolar inflation and that ease of opening on subsequent breaths. But then we're actually assisting the patient with this pressure control or pressure that's delivered on inspiration. It helps to unload the respiratory muscles, to have a larger tidal volume delivered to the patient and better aeration, resulting in better gas exchange. So in this instance, we'll set the expiratory pressure, or the CPAP, and the pressure control level, and again, the FiO2. I will say this can be rather confusing because there's different nomenclature for some of these parameters. CPAP can be referred to as EPAP. You can set the pressure control, pressure support level, and the two combined then get you the peak inspiratory pressure and or the IPAP that's delivered to the patient. Again, it depends upon the device that you're using. So it's helpful to work with the respiratory therapist so that you understand the support that the patient's receiving. Again, typical expiratory pressure, the CPAP level is somewhere between 7 and 10. You would kind of use the same guidelines and clinical assessment in adjusting those. And then the pressure control level that again is set for the inspiratory pressure varies again somewhere between 8 and 12. I think it's important to start on the lower end, and then you can easily increase that to help the patient's work of breathing. This is just a pictorial representation of what this actually looks like. You see the normal breathing on the far left-hand side, where as the curve goes up, that's inspiration, and then on the downward slope, that's exhalation. The pressure then with normal breathing, normal spontaneous breathing, gets to about 0 at the end of exhalation. For CPAP, again, we have the same delta, the same size of breath, but we're just raising that expiratory pressure off of 0 to something like 7 or 8 or 9 to assist the patient to avoid that premature alveolar and airway closure. In BiPAP or bi-level positive airway pressure, we still see that same CPAP level where the whole graph is raised off of the baseline of 0, but then we're adding additional pressure on inspiration to make that change in the volume of air that's moving in and out of the lungs greater to unload those respiratory muscles and hopefully clear some CO2. There are some complications and concerns with using either CPAP or BiPAP, any type of non-invasive ventilation. Because we're applying significant pressure to the upper airway, we can't selectively apply that to the trachea, so you can get some gastric insufflation. It's important to have some sort of tube, either NG or OG tube, to help vent the stomach should that gastric insufflation occur. If there a large volume of gas gets into the stomach, it can actually push up on the diaphragms and impede further inhalation, making the clinical picture and the status of the patient much worse. There can be a pressure injury on the patient's skin due to a poor fitting interface. I'll talk about some of the interfaces that are available momentarily, but it's very important, and Krista will go further into this, that you're looking at the blanchableness of the skin, the pressure points that the device is sitting on, and perhaps rotate those if it's not appropriate. You can also have lack of support. These non-invasive systems are built to operate with some degree of leak in the system. It's not a completely closed circuit. So if there is a large leak that goes unnoticed, we could be looking at the ventilator, assuming that the patient's getting a CPAP of 8 or 9, but actually the pressure within the alveolus is not changing because of this large leak around the interface. So the placement and the fit of the interface is incredibly important delivering non-invasive ventilation. With any positive airway pressure, you can have a risk of pneumothorax. I will say in my nearly 20 years as a respiratory therapist on a neonate pediatric patient or adult, I've never experienced someone receiving a pneumothorax from non-invasive ventilation support. So although the risk is there, I think the incidence is very, very small. These are some of the interfaces that are available. I will use some brand names, but I'm not endorsing those. It's just helpful to describe them. The RAM cannula really helped us. It was a game changer when we talk about non-invasive ventilation delivery. You can imagine, you know, a 2-year-old that you're trying to secure a mask to their nose and mouth. You can't quite reason with them for them to understand the purpose of that. And all they wind up doing is just ripping it off. So the RAM cannula is much more easy to place, much more tolerated by these pediatric and small patients. It essentially looks like a nasal cannula. If you go to the next one, next slide, Ryan. Sorry. Yeah, so there are prongs similar to a nasal cannula and a high flow nasal cannula. However, they're much wider in bore. This allows for a more occlusive fit in the nair. I will remind you that looking at a patient and their external nair is much different than their internal nair. The nair itself actually quickly tapers, And so you may have a higher degree of occlusion than you're appreciating because of the external portion seems different. If you're constantly having a patient where the RAM cannula or nasal interface seems to be pushed out of their nose, it's probably because internally it doesn't fit in that narrow portion of the nair. Ideally, we would like the prongs to occlude about 80% of the nair. The manufacturer recommends somewhere in the 60 to 80% range. But again, in delivering pressures to these patients, we want to make sure that they're actually, their lungs are seeing those pressures and we're getting a therapeutic effect. These RAM cannulas can be used as a high flow nasal cannula. You have to do this very cautiously. The ventilator or CPAP device, whichever you might be using, has a pressure regulation in it. Depending upon what you dial in, that will regulate the pressure, and there are certain alarms built in to stop any high pressure from accumulating. In a high flow nasal cannula system, there isn't a great pressure relief point. So the pressure within the system can build up greatly, and if it's fully occluded to the nair, that pressure will then be transmitted to the patient, and your risk and likelihood of pneumothorax will greatly increase. Securing the RAM cannula should be done very closely and intentionally, meaning that this often needs to be repositioned, perhaps depending upon the pressure injury and the pressure points, needs to be resized and alternated. So you don't want to be taking skin on and off the patient's face. It's great to have something like a Tegaderm on the patient's skin, or use something like the sticky dots or sticky whiskers that are proprietary devices but help save the skin with a protective layer underneath. The septum is where breakdown mostly occurs. You'll either see pinching in a white blanched area right at the septum, or if the RAM cannula is pushed too far inward, then the pressure that the base part of the nasal cannula puts on the septum can cause a significant pressure injury. The question that we often get is, how do I escalate respiratory support? What are the indications? When should I be worried? When should I let the patient try to settle out and see the benefit of the support that they're currently on? These are the guidelines that we use here at Massachusetts General Hospital. They're not set in stone. There's certainly a multidisciplinary discussion around a lot of these changes and movement with these escalation and de-escalation of support. We start high flow nasal cannula, and in strict RSV bronchiolitis, expect the FiO2 requirement of the patient to be very low. So if anything is greater than 0.4 or 40%, that's really indicative of some degree of alveolar collapse. So we then, as a team, decide, would this patient perhaps tolerate and benefit from CPAP? As we put CPAP on the patient, again, we typically start around 7. I would say if the work of breathing of the patient, indicating that the alveolus is more stably open, and or the FiO2 has not improved, then I would consider increasing the CPAP level. My recommendation is to increase it by 2. I think increasing by 1 centimeter of water will take you longer to get where you want to be, and what you would really prefer is to kind of get on the other side and support the patient and then back off on the level of support that you're giving. If you get to a CPAP of 10 or 11 centimeters of water and the work of breathing or the FiO2 continues to be high, that's when we discuss switching to BiPAP. That work of breathing is, of course, marked by accessory muscle use, head bobbing, tachypnea, other things like decreased mental status, and so forth. If on BiPAP, the work of breathing again can persist, and or there's periods of apnea and desaturation, meaning the patient is no longer in respiratory distress, but an impending respiratory failure, intubation is certainly indicated, and you should proceed sooner rather than later. I will say on the the downward trajectory, we kind of follow the same path, that if the patient has escalated to 9 or 10 of CPAP, we decrease that by 1 or 2. I would recommend decreasing it by 2. And then once the patient is on a CPAP of 5 and fairly low FiO2, you can think about transitioning to a low flow nasal cannula. If you feel that the patient needs high flow nasal cannula to maintain their oxygen saturation and worker breathing to be removed from CPAP, I think it's premature to take them off CPAP. It still indicates that there's some sort of alveolar collapse, and CPAP is really the therapy that will open that the best. In helping with all of this and helping us decide in escalation and de-escalation of care, our assessment of choice is the RAS score. We do an eyes-on assessment, and we try to assess the patient together as a multidisciplinary team with the physician, the nurse, and the respiratory therapist. We do have consults, as we're thinking about escalating care, where we, talk to the PICU fellow. Depending upon the severity of the patient, we might ask, one of the critical care intensivists to come evaluate the patient with us. And perhaps we're alerting the PICU to say, this patient is decompensating. We either need a bed right now or we may need a bed in the future. Please just keep us on the radar. The patient's typically made NPO, and some sort of working IV is either established or confirmed. And then there is some type of nasogastric tube placed, whether that's nasally or orally. Again, it's very, very important for venting the stomach and avoiding this increased gastric insufflation from the CPAP or BiPAP levels. Krista will talk a bit about suctioning. It's so important to clear the patient's upper airway, as well as to ensure that the prongs of the ram cannula are not occluded with all of these sticky secretions. And again, I think the rest of this slide captures what I've already mentioned, in that we're starting somewhere between the 6 and 8 range. Again, I would recommend 7. That's probably personal preference. And then if we're getting to 10 or 11 centimeters of water of CPAP, we're thinking about BiPAP. There is a constant reassessment of the team, in terms of, is the patient tolerating it? Have they improved? You should see an improvement, I would say, fairly quickly. Within the first 20 minutes or so, you should start to see the patient improve, perhaps not completely resolved, but at least improving and heading in the right direction. The RAS score that we do use, I think it's pretty commonplace, but for those of you who are unfamiliar, there are 4 parameters with it. It includes respiratory rate, general appearance, retractions, and wheezing. Each of those parameters are rated on a 0 to 2 score. 0 is good and 2 is bad. And then the cumulative score is assessed in terms of, is the patient doing okay, which, would be a score on the lower end. Is their condition guarded, in which we think that we should be increasing support, or are they in trouble where we need immediate assistance and intervention with perhaps intubation? So this is an objectively subjective score. Certainly everyone on the team might have a different rating for the general appearance of the patient, which is why it's very important to have that group discussion and collaboration at the bedside to determine both A, how the patient is now, and B, how they're progressing in their trajectory of disease.
Thanks, Carolyn. Probably to reemphasize that, we really think it's really important to have eyes on the patient and a collaborative multidisciplinary approach. We decided as an institution not to approach these children from an algorithmic standpoint where RAS score of X equals X. I think there's a lot of art to this as well as science, and I think it's important to have several sets of eyes and lots of years of experience helping to assess these patients in real time. Just a real side note here on the RAM cannula. Again, we're not endorsing this, but it was a game changer for us. The name comes from Ramanathan, Dr. Ramanathan, who's an inventor. It's created by Neotech, which is a California company. It was launched in 2011. We use it in our NICU, and it was quite promising. So we were very happy when they started building manufacturing larger sizes for larger children in 2016, which is about when we started noticing a dramatic increase in our BiPAP use using the RAM cannula. Just real briefly, in our respiratory lab with the late Robert Kasmerek, whom Carolyn has expertly taken the place of, a beloved friend and mentor to all of us, we felt it was important that before as we use a new technology, we'd like to assess this technology. So we studied the various RAM cannula that are available, all the way from the white to the purple, from small to large sizes. We typically use orange through purple sizes in our age groups in the PICU, those children with bronchiolitis. We are using an industry standard of using the ASL 5000, which is a lung machine that can detect tracheal, bronchial, and alveolar pressures, as well as a ventilator, and various sizes of 3D printed nasopharyngeal airways of children and the respective sizes of the RAM cannula. We wanted to determine, with 0 to 60% leak, do we see the pressures that we're supposed to be seeing? Does the RAM deliver? And we feel that it does. These are means between the 0 and 20, 40, and 60% leak. And the averages tend to be from the orange, yellow, mint, or green, purple sizes on the right-hand side, that we deliver the pressures for the most part, what are intended, 5, 7, and 10. It's a little bit lower than intended. Maybe another way to look at this is this way, excuse me, that the set CPAP of 5, 7, and 10 below, the measured CPAP on the left-hand side on the y-axis. With 0 leak, we pretty much achieve what we intend, and 20%, 40%, 60% leak, we achieve near what we're intending. With 60% leak, for instance, we actually still maintain even more than 40% of what's intended. So it does a pretty good job. This was done without leak compensation, which most of our ventilators have leak compensation to try to maintain that pressure. So just to say that these simple interfaces work quite well. But what's important, more than just the science, is how these are applied, how they're maintained, how the airways are suctioned. So Krista will take us through that journey. And the nursing care at the bedside, RT care at the bedside, are absolutely paramount.
Thank you, Ryan. I'm here and happy to be with you guys to discuss the nursing implications for patients receiving non-invasive ventilation. First and foremost, when you have a patient that is having increased respiratory distress, we just like to make sure that there are some basic emergency equipment pieces at the bedside. This includes having an AMBU bag, a proper fitting mask ready to go for that patient. Double check your oxygen flow meters. Be sure it is not a low flow. A lot of times, when we have little neonates, sometimes we are using low flow meters. So it's important that, you don't want to try to manually bag a patient with a low flow meter. So just to double check that. You want plenty of suction catheters, as previously mentioned by my colleagues. Suctioning is key, and we'll go over that in more detail. And you also want to elevate the head of the bed for facilitating postural drainage for these patients, and that includes neonates. I know there's a big initiative with, safe sleeping for neonates and being flat, but in this case, we find that, elevating the head of the bed and helping the patients kind of keep the secretions a little bit more at bay, and also open the airways a little bit more to be extremely helpful. Skin protection, Carolyn touched on this a bit. Skin protection is very important. These patients are quite sick, and a lot of the time their interface, whether it be a RAM cannula or a mask, are not just going to be on for a couple of hours. It's usually more like a couple of days. And this kind of, ramps up the risk for skin injury and pressure injury. So prior to placing a mask or a RAM cannula on a patient, we often protect the skin. This is kind of something we do for every patient, regardless of size, age, any of that. We apply a skin protectant We use Cavalon here at Mass General, but I'm sure it's different other places, but that's a Cavalon lollipop and kind of just to protect the skin. And then we'll put a Duoderm down on the cheeks or around the nose and chin area just to protect from a mask if you're using a mask. But it also allows us to then tape or tegaderm the cannula over the Duoderm to help protect the skin, because depending on the child, they're pretty feisty sometimes, and it does require a fair amount of manipulation of the cannula to keep the proper fit for the patient. So rather than ripping the skin off, we're just taping over, you know, the other product, the Duoderm, to kind of limit the irritation. Skin checks should be performed, as Carolyn had mentioned, and documented to identify any areas of breakdown as soon as possible. Especially with the cannulas, we do see a fair amount of breakdown at times under the septum because the cannula is pulled very tightly. So just something to keep in mind. And also, if you have a patient using a mask, a full face mask, it's important to make sure you give the patient a break and perform oral care, brush their teeth, and all of that as tolerated. Suctioning and chest PT. I really can't say enough how vital this is to our patients with bronchiolitis, especially the younger patients, the neonates who cannot effectively clear their secretions independently with a cough. So when choosing an appropriate suction catheter size, you're going to look at the patient's nares and gauge what size. Usually we use 8 to 10 French suction catheters. 6 Frenches, sometimes with the thickness of the secretions are just not able to cut it. We lubricate the end of the catheters very well and slowly and gently insert the catheter into the nose. This is also known as NP suctioning or nasopharyngeal suctioning or nasotracheal suctioning. We pass the catheter several inches to elicit a cough in the distant section of the pharynx. After each pass with the catheter, you want to give your patient a chance to recover. You should not come completely out of the nair during this break, because once the passage of like going down the pharynx behind the curve of, behind your nose, it can be difficult to make that path again. So we often will pull the suction catheter up to the point of not being so irritating to the patient so they can breathe, and then go back down without having to induce trauma again to going back down the entire nair. Continue to suction with breaks to clear secretions as patients are able to tolerate. Troubleshooting for NP suctioning. This is not common practice everywhere, and not everyone finds it to be very comfortable. Mostly the parents and the patients, and nursing as well. It's hard to do. If the catheter will not advance in the nair, you can try having 2 people help hold the patient, and then the other person can advance. Be sure that the catheter tip is well lubricated. And if sometimes you cannot get down one nair and you just need to try the other one, or you might need to downsize the catheter. Nair bleeding, unfortunately, is the lesser of 2 evils. It does happen from the irritation. It's small nairs and they're very friable. We always reassure parents and staff that it is normal to see some bleeding with this. So to optimize risk for bleeding, we try to alternate nairs if possible, try to allow for longer time spans between NP suctioning. And like I said, parents often need reassurance that NP suctioning is vital and the nasal irritation is temporary. Maintaining effective non-invasive ventilation. You want to assess the patient often to ensure the proper placement of the mask or cannula prongs and troubleshoot the fit. Patients are often rolling around in the bed or sleeping on their stomachs and turning their heads. So making sure the mask is fitting or the prongs are still in is vital. Prongs can become clogged with nasal secretions and require intermittent assessment. So it's, you often want to go in the room and take a peek at the prongs and make sure there hasn't been mucus buildup in there, which is impeding the pressure getting to the patient. Ensure the patient has an optimal interface in place, like Carolyn recommended, either a mask or a RAM cannula. Some patients are mouth breathers, and a mask is necessary for the non-invasive to be effective. If they're mouth breathing, the RAM cannula will often just blow the pressure in their nose but out their mouth. Oxygen is able to be titrated based on patient's needs. Weaning O2 to only what the patient requires for adequate saturations is the goal. Use extreme caution in patients that are vomiting, as this increases a risk for aspiration. And as I said earlier, elevate the head of the bed to aid in postural drainage of secretions. Another key component to managing RSV bronchiolitis in pediatrics is fever management. Fevers increase the body's metabolic demand. This causes faster breathing to aid the body in decreasing its temperature. A fever can cause a significant increase in a respiratory rate and work of breathing. Fever management is essential for many patients to breathe more comfortably. We oftentimes will do around the clock Tylenol and Motrin alternating, just to keep patients to stop from spiking fevers, because some kids really look terrible when they have a fever. And it also aids in the comfort of the patient too, because usually if they have RSV, they're feeling pretty junky. Patient comfort. So we decrease stimulation as much as possible. We avoid unnecessary stressors when possible, such as blood pressures, IV placements, lab draws. That includes blood gases, unless absolutely necessary. The more worked up the patient gets, the harder the breathing becomes. Although suctioning is essential, it is important to balance this with keeping the patient as calm as possible and cluster it with other cares. It's also essential to not let the patient, even if these patients often sleep a lot, if they're not feeling great, you just want to be mindful of how long it's been since they were awake and mobilizing those secretions. You don't want to let them sleep for hours and hours on end, because it can kind of set you up for a little bit of a backslide when they wake up. Tylenol and Motrin for comfort as needed. And then something we'll talk about next, which is allowing the patient to PO feed. PO or NG tube feeding while on non-invasive. It may be essential for patient comfort. A lot of patients are just miserable while they are NPO. A study was done in our PICU amongst my colleagues that indicated that this can be done safely, but on a case-by-case basis. Factors to be considered when determining if a patient is appropriate to PO feed are, how is the patient's work of breathing? Is it conductive to being able to breathe and eat simultaneously? Is the patient grunting, sputtering, or desatting while trying to eat? What is the RAS score? Is the patient's RAS score increasing? Are you more concerned that the distress is getting worse? Are we escalating care versus decreasing and starting to wean from BiPAP to CPAP, or weaning down on your settings? Is the abdomen grossly distended with air from the non-invasive ventilation? And is the patient even interested in PO feeding? Some patients, like I said, are totally miserable while they're NPO, but other patients just feel so junky that they're really uninterested in feeding. So PO or NG tube feeding while on non-invasive. So Pedialyte is the best option to start with while determining if the patient is able to tolerate feeding. NG tubes can be helpful for feeding and decompressing air from the patient's stomach. However, assessment for impeding cannula placement or mask function is necessary. We always find it best to NP suction the patient, so nasopharyngeal down the nose suction patients, clean them all out before offering them a feeding. This helps decrease the risk for vomiting and also makes PO feeding easier with clear breathing passages. What about feeding? This is a little synopsis of, like I had mentioned before, a study done in the PICU here at MGH by some of my colleagues. Is feeding safe in children with bronchiolitis? The background of this, respiratory illnesses are the leading cause of pediatric admissions, with bronchiolitis being the most common. Treatment is supportive care, including oxygen therapy delivered by non-invasive ventilation. Non-invasive ventilation consists of high flow nasal cannula, CPAP, and bilevel positive pressure, which is BiPAP. Feeding practices for children receiving NIV vary due to paucity of evidence-based guidelines. There's not a lot of research out there about this. Initial literature review yielded 2 articles that are eligible for inclusion. Both articles indicated that oral feeding on high flow nasal cannula is well tolerated in this population, and there are no articles involving CPAP or BiPAP. The study. So the purpose is to compare incidences of complications when initiating oral feeds compared to feeds by NG tube in children receiving non-invasive ventilation for bronchiolitis. Methods. We conducted a retrospective study on children ages 0 to 24 months admitted from the year 2016 to 2020 with a diagnosis of bronchiolitis. We excluded those who had a gastrostomy tube or G tube. Primary outcomes were complications related to feeds, emesis, increase in respiratory support after feeds, aspiration diagnosis requiring antibiotics, and increased length of stay. Other factors documented during the chart review included time to first feed, RAS score on admission, and RAS score at the time of the first feed. So some of these numbers for results. So as Ryan discussed earlier, as you can see from this slide, the non-invasive use from 2016, which is 6.25%, to 2020 went up to 86.4%. So the use of non-invasive ventilation for bronchiolitic patients drastically increased over the past 4 years, as did how much we allow them to PO. So the patients that were able to PO on CPAP in the beginning of the study were 7.7% and has risen to 38.1%. And likewise with BiPAP, we didn't let anybody PO feed on BiPAP at first when the study initially started, and then it went up to 39.7% in 2020. The incidence of increase in respiratory support after the first feed was noted for PO feeding more so than NG tube feeding. And the frequency of increase in support after first feed overall did go up, but not very much. And there's a lot of contributing factors to that. We found while doing the study that even if the patient became a little bit more tachypnic after a feed, it often was temporary and outweighed, the risk of having, fluid overload from too many IV fluids, or having to use a medication like Precedex to keep the patient calm and tolerating the mask, where if you could just give them a bottle, yes, they might have an increased work of breathing for a half an hour afterward, but it might alleviate the need for any type of sedative. And the aspiration was 5%, but that was for all patients throughout the whole study. So it was everyone on high flow, CPAP, BiPAP. They were either NG tube feeding or PO feeding. It did not show any sort of correlation between one mode of ventilation than the other, or even NG tube versus PO feeding. This was another article which also showed that the majority of patients that were fed while on high flow nasal cannula was greater than CPAP, and the respiratory rate was actually reduced, and there were no aspiration events. Also, one other thing to mention with the study that we did at MGH was that it, even if there was a little bit of escalation in settings for CPAP or BiPAP, it did not it did not equal like an increased length of stay for these patients. Sorry, Ryan, I made you go back.
That's great. Thanks. So maybe to sum up, Respiratory distress bronchiolitis was already on the rise, and we're all dealing with the current spike. The use of non-invasive ventilation was already increasing and now in super high demand. Non-invasive ventilation, CPAP and BiPAP, as we talked about today. Some people will actually add a high flow nasal cannula to that category. And you discussed that quite a bit last week. We think this gentle pressure is used to keep open these sick, sticky lungs. Overall, it's very simple, easy, and safe, but requires vigilance, requires a multidisciplinary approach. We recommend using a subjective, objective scoring system just to help in communicating between different care teams. Suctioning and maintaining a strong seal are absolutely paramount, as expertly discussed by Krista and Carolyn. And consider feeding by PO or NG tube as a safe alternative to sedation, again, on a case-by-case basis. So thank you for your time. We see a couple of questions. We're giving a little bit of time left over to address these questions. Any further questions?
Definitely, thank you. So thank you to everyone for submitting your questions. I think we checked a few of them off as our speakers continued. So we have time for a couple. Right now I have one which was posed: has there been any research regarding the efficacy of therapy between humidified CPAP or BiPAP versus a dry circuit or HME? And do you recommend one option over either of the others?
So I can try to field that. There are no studies that I'm aware of that compare these. There certainly are studies that look at the efficiency of HMEs that are basically equivocal to a heated humidifier for intubated patients. I would recommend and prefer an active humidifier for patients with RSV bronchiolitis. The secretions are incredibly thick to start with, and HME works based upon the exhaled humidification and water content of the gas of the patient. These patients are typically dehydrated, their airways are already dry, so what is being exhaled probably doesn't have enough water content to then be captured within the HME and further rehumidify the inspired gas. So if it's available to you, I would suggest using an active heated humidifier. If all you have is an HME, it's certainly better than nothing.
Yep.
Thanks for that, Carolyn. And so one other question that we've seen come through is talking about initially placing and stabilizing patients on non-invasive ventilation. So Carolyn, you touched on kind of where to start. Some of the questions are, how quickly do you escalate? What does this pathway look like, especially in facilities where pediatric patients aren't kind of their bread and butter?
Yeah, so again, I would say start with 6 or 7. And if the patient hasn't improved in a short period of time, I would say that you're probably looking to see some sort of improvement within the first half an hour. By an hour's time of being on CPAP, they should look much better. If they haven't, if they're still, have an increased work of breathing, desaturation, perhaps, a high O2 requirement, I would say waiting any longer than an hour to reassess and further increase is just going to set you back. You really should see an improvement fairly soon. So once you kind of stabilize the patient, that then begs the question about how do you de-escalate care in these settings? And we use kind of similar guidelines. If you're able to have a really low FiO2, perhaps Romer 24%, 28% on, some level of CPAP, you can think about decreasing that. If you decrease it and the work of breathing goes up or the oxygen requirement goes up, you should immediately re-establish your CPAP level that was therapeutic. An increase in oxygen, even if it's minor as you're weaning CPAP, indicates that you've now induced alveolar collapse to some degree. Might not be overwhelming, but you're kind of setting yourself up and the patient up to further decompensate as more collapse is evident. So I would suggest that if you wean it and within a half an hour or an hour, you're requiring more oxygen, you should go back up to the previous setting where the patient was on stable oxygen.
Thank you so much for that. We are just at time. I do have one other question, but as folks log off, if you're able to complete the survey by scanning the QR code on the screen, that would be great. Krista, I'm going to turf this question to you. We are here at MGH at a very large hospital. The question is, any tips out there for nurses who have very little respiratory therapy support? And so probably a Krista Ryan combo for that answer.
I'd be happy to answer that as best I can. So all of the things that I pretty much discussed during my time talking with you guys was all nursing indications. Like, we don't use respiratory therapy per se to do any of those things that I had discussed. We do all of our own suctioning. Like I said, it might take 1 or 2 nurses to kind of tag team together. But that is something we typically do on our own, along with the chest PT, maintaining the placement of the interface and all of that. Respiratory does do their rounds and checks in, but it's really the responsibility too of the nurses to make sure that the placement is all right and doing all the skin checks. So all of those things that I mentioned are things that our nurses do here at MGH as well. And especially, like I said, I couldn't stress enough, even temperature management. The kids with the fevers look terrible, and keep them going with Motrin and Tylenol as ordered.
Excellent, thank you. And I think to some of the points that all the panelists made, whatever interdisciplinary team you have at your disposal, bringing those perspectives together. So whether it's nursing and provider, or if there is the respiratory therapy support, bringing those together to come up with a plan for your patient, I think is one of the big themes that stood out for me today. So we are 2 minutes over. So I want to thank everyone again for joining us today. We have a few questions in the chat that we didn't answer that we will look at putting some resources on our website for. And we really appreciate you taking the time. We will have 3 more of these sessions continuing on Wednesdays at noon Eastern time for the next few weeks. Appreciate it.